All right. All right. Good afternoon, everybody, and welcome to Pulmonary Grand Rounds. As I mentioned in my email this morning, I've been waiting for this lecture for a long time, and it's my special pleasure to introduce my friend and colleague, Dr. Astha Chichra. For those of you who have not had the pleasure of getting to know her yet, she's an associate professor in the Pulmonary Critical Care and Sleep Medicine section. She got her MBBS from Kasturba Medical College in Mangalore in 2008, then went on to do her internal medicine residency and pulmonary and critical care fellowship at Hofstra North Shore. She then went to Tulane for a few years, but we were lucky enough to snag her. And she came to Yale as an assistant professor in 2018 and has risen through the ranks since then. She has a lot of core roles in our hospital and in our section. She's associate medical director of the medical intensive care unit. She's a medical director of the 10-7 Progressive Pulmonary Care Unit, and she serves on the Yale School of Medicine POCUS Council. She is a widely sought after speaker in her areas of interest, both nationally and internationally, in topics such as the use of ultrasound and ECMO, which we are going to hear about today. She has 10 peer-reviewed original research articles, 4 reviews, and 8 editorials to her credit. And she's very much one of our core critical care faculty and leaders in our section. And from my perspective, this is the person I would call first if I had a question about ECMO. There's no question in my mind. So I always look forward to your email every time I'm about to go into the MICU, because I know there's someone out there who I can turn to if I need her. And so here we are. We're going to learn about the ABCs of Veno-venous ECMO. Astha, welcome to the podium.
Thank you. Thanks, Mark. Thanks for that kind introduction. So today we'll be talking about VV ECMO and really going through some of the basics of not just things that happen before ECMO, which we are maybe all familiar with, but also what happens to the patient once they are on ECMO. This is for CME credit. Okay. I have no disclosures related to this topic, unfortunately. So my objectives today. So we'll start off with defining ECMO terminology to really make sure that when we are using certain terms, we all know what they stand for. We'll go over some common circuit configuration and components. We'll review key clinical trial data related to ECMO use. We'll identify indications and contraindications for ECMO. And then go over management strategies of patients on ECMO, including their ventilatory management, anticoagulation, and monitoring. We'll also learn about some common complications that we encounter on patients who are on ECMO. And then finally, how we go about thinking about weaning and decannulation from ECMO. So to start off, we all use this term a lot, MCS, or mechanical circulatory support. So to be clear, this is circulatory support, so cardiac support. But it falls into 2 broad categories of temporary and durable. For temporary, this would be both intracorporeal, so things that you may have seen in the CCU, like impeller, balloon pump, or extracorporeal, which includes ECMO. The more durable form of MCS is something called LVAD, which patients now live with, and you'll probably encounter once in a while, especially here in our hospital. Going to ECMO in particular, so there are all of these terms, and they refer to a whole bunch of things about ECMO. It is important to understand them because there is some subtle differences. So the first term is extracorporeal life support, or ECLS. This is really an overarching term for any extracorporeal support for both cardiac and pulmonary support. It includes both VV, veno-venous ECMO, VA ECMO, and something called extracorporeal CO2 removal, which we'll touch on briefly. Then ECMO, which is sort of a broad term we all use, let's call for an ECMO consult. It is also used broadly, again, refers to any kind of extracorporeal support, which is using an external pump, oxygenator, and cannula, capable of providing flow for oxygenation and circulatory support. So again, it essentially stands for both VV and VA ECMO, not so much for the extracorporeal CO2 removal. VV ECMO, which we are really going to focus on today, is veno-venous ECMO. So this is supporting the lungs or your respiratory system and helps with both oxygenation and carbon dioxide removal. VA ECMO or veno-arterial ECMO is to support the circulatory system, so really helps with cardiac output support, but it does provide some respiratory support as well. And then extracorporeal CO2 removal, not something that we really do here, but is certainly something that's maybe being studied, is similar to VV ECMO in that it's a veno-venous system, but it's the difference being that the flow rates are very low. And you're really just supporting removal of CO2 with this, not so much oxygenation. And so sort of a low-level VV ECMO support, just supporting hypercarbia. So with this kind of overarching theme for ECMO, any kind of the indication for any ECMO is maybe just severe circulatory or respiratory failure. And so we are all correct in saying when we call for ECMO support, maybe we don't quite know whether we need circulatory or respiratory support, but I'm hoping by the end of this talk, you'd be able to differentiate a little bit between when you need the VV and when you need VA. So briefly going over the configuration of veno-venous ECMO. So this would be a very typical configuration that we see. Here we have the drainage cannula that usually comes from the femoral vein here, a blood pump, oxygenator, and then oxygenated blood going back through an IJ cannula. This is probably something you've seen pretty often at the bedside. Sometimes our surgeons will come and cannulate the patients with this configuration. Another configuration that commonly exists in veno-venous ECMO is IJ only. So this would be one single lumen cannula with both the return and drainage cannula built in. It's something that that we here at Yale don't do as a starting point. We usually convert people from a FEM-IJ or a FEM-FEM support to do a lumen IJ, but really is being done in many medical ICUs across the country as a primary mode for support. Briefly about VA ECMO. So remember, this is to support patients with severe circulatory or cardiac failure. This is giving you that cardiac output support. Common configuration that we end up seeing, say if you call for ECPR and the patient gets ROSC and they now have put the patient on VA ECMO, is where you will see them put in a femoral drainage cannula here in the femoral vein, again, a pump, an oxygenator, and the blood getting returned to the femoral artery. So fairly common. This is something that we even are doing on the floor now as part of ECPR. So something to be familiar with. So again, this is one of the more common configurations that we see, which is FEM-FEM. The other one would be like a central ECMO, which we will thankfully never encounter in the medical ICU, mostly in the CT ICU, where this is an open ECMO centrally placed. This is how these cannulas look. So they are fairly large, similar in veno-venous ECMO. And this is a FEM-FEM configuration that you see here. So switching gears and focusing more on VV ECMO, we'll start off with a case. And I'll go over two common scenarios that we get called for fairly frequently. So the first 38-year-old male with no real past medical history came in with COVID ARDS. A familiar story for all of us from a few years ago. This patient received the usual COVID therapy, which was Decadron, Remdesivir, Toci, initially on high flow, but progressed and got intubated on day 9 of admission. Received all the standard therapies for ARDS, including proning, paralysis, pulmonary vasodilators, but unfortunately, the course was complicated by refractory hypoxemic respiratory failure and barotrauma. So this chest X-ray, which is portable, is not the best, but you see this arrow here showing the pneumomediastinum, and the patient had fairly significant subQ emphysema as well. So in this setting, what do we do next as an intensivist, right? We have the patient prone, we have the patient paralyzed, we have them on nitric oxide, EPO, whatever you're using in the minute, and the patient is still hypoxemic. The second question, the second case, similar sort of case where we are maybe pushed to a corner. This was a 21-year-old female with asthma, history of childhood asthma, came in with a severe asthma exacerbation. She had a brief trial on non-invasive ventilation, but was quickly intubated within hours of presentation, with the ABG at the time of intubation with a pH of 717 and a CO2 of 62. Post-intubation, just like most of these asthmatics, she was really hard to synchronize to the ventilator, required sedation, paralysis, but still persistently had severe autopep of about 12 to 15. And despite the bedside intensivist's best efforts, the hypercarbia kept progressing and the autopep did not improve, with the lowest pH of 7.07 and a PCO2 of 98. This was her chest X-ray. No real barotrauma here, nothing that we could really fix. It just looks like a fairly normal chest X-ray. And in situations like this is when we kind of pause and say, have we really run out of options, or are we just running out of time? And it's sometimes hard to discern the difference between the two, especially in patients like asthmatics, but maybe that question is why we have this modality of VV ECMO. So I'll talk a little bit about respiratory failure. It's estimated that about 2 million people are hospitalized in the US annually with acute respiratory failure. This data is predating COVID, so it's old. So you can imagine the numbers have probably gone up right now. And the cost of taking care of these patients exceeds $50 billion annually. Approximately 50% of them require invasive mechanical ventilation, and mortality exceeds 20% in these patients even now. And we've been using the ventilator for a while, since really the 1950s polio epidemic, so we've become rather good at it. But sometimes the ventilator is just not enough, just like those two cases. And sometimes it causes its own complications, like our first case with barotrauma. And so consequently, there is often a need for alternative modes of respiratory support. And maybe that is where the role of VV ECMO starts. And so really when lung protective ventilation isn't enough is maybe where we start thinking about VV ECMO. And I hope to kind of convince you by the end of the talk that maybe we don't just reserve it for the very last salvage therapy cases. So what is the goal that we are trying to achieve in these patients on VV ECMO? So for decades, our focus in ARDS was simply oxygenating patients, right? And that was thought to be the major goal for ECMO as well, thinking this would improve survival. But we know over the past few decades that survival is not determined by fixing the hypoxemia alone, but maybe trying to prevent the injury that we cause while trying to fix the hypoxemia. And so since the major cause of mortality in patients with severe respiratory failure is ventilator-induced lung injury, ECMO lets us provide that lung protective ventilation to reduce ventilator-induced lung injury. It also, as a side, helps us to minimize sedation. It helps us liberate patients faster from the ventilator and mobilize patients. The last three are particularly relevant when you're thinking about patients who maybe you're going to transplant. So if the promise of ECMO is lung rest and injury mitigation, the obvious next question is, does that translate into improved clinical outcomes, right? As an intensivist at the bedside, that's what I want to know. Are my two patients going to survive if we put them on ECMO? And so for that, we look at some evidence data that we have. I always like to start with some historical background. I think it's interesting. And so when you look at it, ECMO was first successfully deployed in a patient with ARDS in 1971. This is an interesting case. It's actually an interesting read, this paper. But it was a 24-year-old man who came in with blunt force trauma. And they used something they call Bramson membrane heart-lung machine, which is really ECMO, and supported the patient. And if you notice here, the PO2 increased from 38 to 75. The FiO2 that the patient needed reduced from 100 to 60%, and the peak airway pressure reduced from 60 to 35. and the patient survived. So the authors concluded that this is a feasible modality to support someone with respiratory failure. This was the Bramson membrane lung that they used. So if you notice here, actually, both the cannulas are here on the femoral. This was actually a VA ECMO support that they used, which, like I had mentioned previously, can support respiratory failure as well. And so there was some interest after this, and it was followed by a few case series, some intermittent case studies here and there. But then there were 2 negative randomized clinical trials in 1979 and then 1994. The first one in 1979 was in severe acute respiratory failure. It was across 9 medical centers, and they looked at 90 patients with severe respiratory failure. And unfortunately, they had pretty dismal survival rates. In both the groups, only 4 patients survived in each group. All patients with PE and post-traumatic respiratory failure died. And the authors concluded that while ECMO is feasible, it's no better than conventional modalities and does not improve survival. This was their survival curve here with mechanical ventilation here, and then the -1 vent and ECMO. And so really, why was that? It probably was because the technology in that era was just not as developed, and it led to multiple complications such as bleeding. Also, many enrolling centers didn't really have much experience with the device, considering it was a very new modality at the time. And more importantly, the survival rates in both the groups were pretty poor. So probably we just didn't know enough about ventilator-induced lung injury at the time as well. So this, between 79 and 94, we really just have some case series and case studies again. And then the next RCT is in 1994. Speaks to the fact of how hard it is to do RCTs in our ICU population, maybe. But this was done by Morris in just 40 patients, where it was a single center study. And they randomized patients with severe ARDS to either extracorporeal CO2 removal that we had briefly talked about, or sort of a slow form of VV ECMO, if you will, with inverse ratio ventilation, or just to conventional management. Again, they stopped the trial early for futility here with no significant survival difference. But actually, if you look at it in the intervention arm, the survival was poorer. So that's the ECMO arm, just 33% survived. And there were some major adverse events with increased bleeding in the ECMO group. This was primarily, again, felt to be related to aggressive anticoagulation that they required at the time, because the circuit and all its components were intensely thrombogenic. And so subsequently, ECMO for respiratory failure was really just left to a few large centers, some case series, some case studies here and there. But the technology, thankfully, did keep developing. It was primarily used for cardiopulmonary bypass, pediatric ECMO, and really there were considerable advancements in pumps, membrane lungs, biocompatible coated surfaces, cannula. And so things did keep moving. And then in 2009, there was an inflection point in the use of ECMO because of the confluence of 2 events. The first was the Caesar trial that was published in Lancet, and the second was the H1N1 pandemic. So the Caesar trial, we'll go over it in a little bit of detail, because really this is the one of 2 RCTs in recent times that we have. This is a multi-center trial in the UK aimed to compare ECMO with standard of care in patients with severe ARDS. They enrolled about 180 patients who were randomly allocated to either ECMO or conventional management. But only 75% of the patients who were allocated to ECMO received ECMO. And the ones who were allocated to the ECMO arm, 63% survived without disability compared to 41% in the conventional arm. But this trial was really heavily criticized because a large percentage of patients in the ECMO group never received ECMO. And secondly, in the conventional group, standard ventilatory practices were not followed. So a large number of patients in the control group received larger than recommended tidal volumes. And we did know by then that low tidal volume ventilation is one of the mortality changing outcomes in ARDS. But on the positive side, only 2 serious adverse events were reported in the ECMO group. So one patient who died prior to undergoing cannulation because of a failure of oxygen supply in the ambulance, and the second patient who died as a result of cannulation-related complications. And so while the Caesar trial did not demonstrate efficacy, it was an important trial that demonstrated relative safety compared to that 1994 trial. And really maybe could be interpreted in different ways depending on what you believe about ECMO. And then, like I mentioned, in 2009 was also the H1N1 pandemic. And there were many kind of case studies, case series, retrospective looks from the time, but there were 2 major ones that you maybe are worth mentioning. One is this one published in JAMA, which came out of Australia and New Zealand out of multiple ICUs at regional referral centers who received multiple patients referred for severe respiratory failure. And about a third of these patients received ECMO. These were their mortality indices, so really about 23% mortality in the ECMO group. But notably, the ECMO group was considerably younger. They were young adult males. So maybe not that convincing in favor of ECMO here. There was also a similar one coming out of UK. Here there were 80 ECMO referred patients, so similar to Caesar. 69 of those who received ECMO, and they showed that the patients who were referred to an ECMO center did well after multiple sort of either individual matching or propensity score matching. And the authors concluded that maybe for patients with H1N1 related ARDS, referral and transfer to the ECMO center is associated with the lower mortality, not so much receiving ECMO. So I think both the Caesar and this data didn't convince us that ECMO is a strategy that could be and should be used for ARDS, but it did maybe say that it was safe to be used. But it secondly really maybe firmed the belief that conventional mechanical ventilation with just good ventilatory practices does make a difference. And then sort of timely, now that we look back, came one of our only RCTs in recent times in 2018, which was the EOLIA trial. This was a prospective multi-center randomized control trial. And the authors asked the question, does early initiation of VV ECMO in severe ARDS improve mortality? Their inclusion criteria were fairly strict. So if you see P2F less than 80, driving pressure more than 60, intubation days less than 7. And the exclusion were kind of fairly obvious, someone with long-term respiratory failure or cardiac failure, which we cannot support with VV ECMO. So, really the patient had to fail conventional medical therapy to be included. So in the intervention group, the patients received ECMO and their PO2 and PCO2 were tightly controlled. They received really ultra lung protective ventilation, aiming for a plateau pressure less than 24. But in the control group, compared to Caesar, this trial also controlled their ventilation. So the control group all got lung protective ventilation with strict targets of plateau pressure, proning and paralysis were encouraged, and adjunctive therapies were allowed. So this trial enrollment stopped at 75% because, again, it was hard to recruit patients for the trial. But there was no significant difference in mortality between the ECMO and the control group based on a p-value of 0.09. If you look at the actual numbers, the ECMO group had a mortality of 35% versus the control group of 46%. And the ECMO group also did have significantly lower risk or relative risk of renal replacement therapy, treatment failure, proning rates, and higher risk as expected of bleeding events and thrombocytopenia, which is a circuit-related complication. Importantly, 28% of patients in the control group crossed over to ECMO for refractory respiratory failure, which they defined as a SAT less than 80%, so fairly strict for 6 hours, despite all of our usual methods. The patients who crossed over was sicker by the time they got ECMO and actually had higher mortality than patients in the control group who did not cross over to ECMO, maybe suggesting that if we have to pull the trigger on ECMO, it probably needs to be sooner than waiting for the patient to get too sick. And so what did Eolia taught us? Although the authors concluded that there was no benefit with the use of ECMO versus conventional therapy, I think we can conclude that early ECMO may benefit the sickest patients. There was a 28% crossover, which is about 32 out of their 125 patients. 15 of these 35 patients survived, and it is unlikely any of them would have survived without ECMO. And so the takeaway from Eolia is not maybe that ECMO does not work. It is that who we put on ECMO and when we do it matters. This was corroborated by a meta-analysis of both Caesar and Eolia. This was a pooled analysis that demonstrated that VV ECMO probably did decrease mortality at the follow-up. This was the ECMO group and the conventional group pooled analysis of Caesar and Eolia. And of course, after 2018 came the big use of ECMO. This is where at Yale we started using VV ECMO a lot, which was the COVID-19 pandemic. Now, unfortunately, data from the time is mostly a lot of case series, a lot of look-back retrospective analyses. This is one of the biggest ones worth looking at. This was a retrospective examination of 4,800 patients in the ELSO registry who received ECMO. And the authors looked at it interestingly. They divided the centers into those that adopted ECMO early on in the pandemic versus later on, which they defined as May 2020, so that first wave. And they saw that centers that adopted ECMO early on did much better in terms of mortality versus this group B, which was the late adopting. And even within this early adopting center, which was A, they divided into A1 and A2, A2 being later in the pandemic, and again, they had worse outcomes. And so the conclusion of this was that, well, maybe is it just that patients who are failing regular therapy are just destined to do poorly? It's hard to know. Maybe we were just quicker to put patients on ECMO and we're just using it too much. That's quite possible. And we were using things like non-invasive ventilation a lot, high flow a lot, and maybe the total duration of ARDS was pretty prolonged. We don't also know how this compares to patients who were denied ECMO. And so with all of this, actually, the ATS guidelines for ARDS was updated in 2024 to include VV ECMO as a conditional recommendation in favor. So again, not over prone positioning or neuromuscular blockade, but to be considered if those fail. And so maybe the trials didn't tell us that you put everybody with respiratory failure on ECMO, but they did tell us that you need to be selective. So what do we think about when we get called for ECMO? When we are getting this call as ECMO team, we are thinking about, is this patient falling into three of these major categories? So one is this ECMO going to be a bridge to recovery? So this would be something like a reversible respiratory failure, think status asthmaticus or the COVID ARDS patient we spoke about. Is it a bridge to transplant? So someone who is listed awaiting transplant with irreversible or chronic respiratory failure? Or is this a bridge to decision? So this bridge to decision is where we just don't know if this patient is a transplant candidate, but if with careful multidisciplinary discussions and open and transparent discussions with the patient's relative, we determine that a course of ECMO is warranted to see how the patient does, to see if their workup reveals that they are a transplant candidate. It can be considered in those cases too. Common causes of reversible respiratory failure that we put patients on ECMO for would be ARDS, severe pneumonia, severe acute asthma, chemical inhalation, hypersensitivity pneumonitis, near drowning, lung contusion, autoimmune lung disease, burns is something we've done a few times, and as support for thoracic surgeries. Irreversible or chronic respiratory failure, again, this would be a bridge when patient is waiting for lung transplant already. And we know that ECMO in conjunction with early liberalization from the ventilator, minimal sedation, really aggressive rehab, aggressively improving their nutritional status, is helpful for these patients while they're awaiting organ donation. They do actually, when they looked at studies, they've now, with these more modern things, they do see that the outcomes of patients receiving ECMO before transplant and those who don't are fairly similar. And so this is one of those dual lumen IJ cannulas that I was telling you about, and the patients being mobilized on ECMO. Something that we have tried to do here as well. And then, thinking about the more granular details of when we are thinking about ECMO. So for hypoxemic respiratory failure, it would typically be a P2F less than 80 after optimal medical management, or hypercapnic respiratory failure with the pH less than 7.25, despite, again, ventilatory adjustments, or as a bridge to transplant for those waiting lung transplant. So really, both our cases in the beginning were falling into this category for consideration of ECMO. Some of the contraindications that we think of, there are a whole list of relative contraindications, but some of the more important one is that if someone's been intubated for more than 7 days, if they have significant neurological injury, recent intracranial hemorrhage, if they have contraindications to anticoagulation, not so much a problem with VV ECMO, but still something that we consider. And age, while there's no specific age cutoff, we do know that there is worsening outcomes with advanced age. There's really one absolute contraindication, which would be anticipated non-recovery without a viable plan for decannulation. So think it's not just the disease process, but in the context of maybe multi-organ failure or other comorbidities. And there are multiple scores to think about these indications and contraindications. None of them, I think pan out extremely well, but they're very intuitive. The most widely used one is something called the RESP score, which is a tool to predict in-hospital survival for adults needing ECMO. And they assess multiple factors like age, immunocompromised status, ventilation, CNS issues, to decide on ECMO use and manage expectations, because it is helpful for expectation setting for families. This is kind of how the score does. You can actually plug it in on MD Calc, it's available, but the lower the score, the worse the outcomes. So our 2 patients in the cases there, we decided to call for ECMO, and they both got cannulated. So it's worthwhile reviewing a little bit about how ECMO works. I think it's something that as intensivists, we need to have some sort of a basic knowledge for. So these are some basic components of the ECMO circuit. So like I said, this is the drainage cannula from venous side, because this is veno-venous ECMO. Here's the blood pump. Then it goes through an oxygenator. Before that, there's a pre-membrane blood gas analyzer, a pressure monitor, and then after that, again, a post-membrane blood gas analyzer, a pressure monitor, and then return to the patient via the return cannula, whether IJ or femoral. And so just like a ventilator, if there is any problem or if there's troubleshooting to be done, we look at all of these components to figure out what and where are things going wrong. So how do we determine oxygenation in VV ECMO? So oxygenation is determined primarily by the blood flow rate. And so when you look at your flow sheet, there is a flow mentioned in ECMO, which is anywhere from 3 to 4 to 5. That is what is determining your oxygenation. Going back to physiology, so this is our oxygen delivery formula, which is equal to flow times the oxygen content of the blood. And so really similarly for ECMO, quantity of oxygen is the product of ECMO circuit flow in liters per minute minus the inlet oxygen content of the blood. So this is sort of, the standard things. I'm sure you all remember this formula, what determines oxygen content of the blood. But those are all things that we look at to determine what's happening with the oxygenation. So when you crank up the flow, you are exposing more blood to the oxygenator and you're improving oxygen. This is really relevant for patients who inherently have a higher cardiac output. So think patients with septic shock or just sepsis. Some young patients, obese patients who are known to have high cardiac output, and they require a really high flow for us to be able to oxygenate them. Because what we are aiming for is 60 to 80% of cardiac output as ECMO flow. And so if someone already has an inherent 12 liters per minute, it's really hard for us to keep up with that on ECMO. The membrane FiO2 or the FiO2 in that oxygenator is something you can manipulate, but we typically keep it at 100% and manipulate the flow. So what is limiting us to increase the flow? It's the cannula size. It's literally how big the hose is that's going in the patient. And so this is sort of reflective of what we are looking for. So a BMI less than 40, we are looking at something that can flow about 4 to 5 liters per minute. So sort of our normal standard cannulas versus someone with a higher BMI where now we need higher flows and sometimes we need to put in a third ECMO cannula to support them. It is not an absolute contraindication if they do have a high BMI, but we do have to go in being prepared that we may run into big trouble. And why don't we just increase the flow on everyone? Like, what's the problem? We'll put in those 3 cannulas and just increase the flow. Well, it's because you have to weigh the risk of complications that happens when you increase the flow. So you're causing more blood to go through the circuit, which causes more hemolysis. It causes something called recirculation that we'll talk about in a minute, but also causes chattering, which is when you increase the flow, the suction causes the vein to kind of collapse around the cannula, and it leads to just trouble flowing on the ECMO. So recirculation is something important for us to know about in VV ECMO. As pulmonary consultants in the CT ICU, you may get called, oh, hey, we are having difficulty oxygenating these patients. Most of the time they have looked and thought about this, but this is something to know about. What does it refer to? So it basically refers to the post-oxygenator blood. So here, this is coming through the reinfusion cannula, going directly back into the drainage cannula instead of going through the tricuspid valve to go into the patient circulation. This is more common with our single lumen cannulas, which is why you need to be a little bit more careful about how it is placed. And you can get tipped off by seeing just a really bright colored blood in the drainage cannula. We check blood gases, both pre-membrane, post-membrane, to sort of see what's happening. And what tips off the intensivist there is that as they're increasing flow, it'll actually cause a paradoxical decrease in circulation, in saturation, because you increase the recirculation. And you prevent it by confirming cannula position and spacing every day. You can use bedside echo, TEE, just regular imaging to confirm the position. The second reason that, of course, we've put someone on VV ECMO is for CO2 removal, and this is controlled by something called the sweep gas flow rate, and that's something that the perfusionist is always looking at. It typically ranges from 1 to 9. And this is important to think about because we do know that we can rapidly correct PCO2, and that can be really harmful for patients. Again, this is something that actually has come up lately in the last decade or so, so worth thinking about. This was a study of about 12,000 patients in which the authors showed that if there was a more than 50% drop of PCO2 in the first 24 hours on ECMO, it led to worse neurological outcomes. And by worse neurological outcomes, I mean worse neurological outcomes in every way, including seizures, intracranial hemorrhage, brain death, and mortality. What is the mechanism of that? So it's sort of similar to when we have a post-cardiac arrest patient and we are thinking about their PCO2. But if we acutely decrease the blood PCO2, you'll alkalinize the CSF, cause cerebral vasoconstriction, which decreases the blood flow, causes neurological injury. Of course, other things contribute, like what is the disease factor itself maybe is contributing. If you've suddenly increased the PO2 and other ECMO-related factors that lead to hemolysis and thrombocytopenia. But this part is something that we do try to control. So for example, that status asthmaticus patient with the pH of 707, if we drop her PCO2 from 92 to 40, we are expecting bad neurological outcomes. So it's something to communicate to the perfusionist right away that, hey, we don't want the sweep gas to be set at 8, even though the PCO2 is 9. Now, once the patient is on ECMO, what kind of vent settings are we doing? So really remember, the primary advantage of VV ECMO is that it is allowing us to do ultra lung protective ventilation with really low tidal volumes, low plateau pressures, and reduced respiratory rates. So we really want to reduce the risk of barotrauma without sort of worrying about acidosis or oxygenation. And so typically we will set really low respiratory rate, anywhere from 4 to 30 is what ELSO recommends, but we'll leave them on a rate of about 10 and kind of forget about it as long as it's not causing auto PEEP. FiO2 as low as possible. And the PEEP usually, somewhere very safe, and I think at baseline about 8 to 10 is what we choose. Just really going for a total plateau pressure that ELSO is recommending of less than 25, but even more lately, people are really even going for a plateau pressure less than 20. And if there's major barotrauma with like a bronchopleural fistula and air leak, we can even take the ventilator completely off and essentially put them on flow by to promote healing, as long as we can manage everything else with the circuit. This is very similar to the strategies used in both RCTs with Eolia and Caesar. So Eolia in particular, if you remember, they really were going for a plateau less than 24. They also used APRV in some modes, but this is something that we will kind of commonly do. Other things to know about, and this is probably something that you've all encountered, when our patients get initially placed on VV ECMO, it leads to some abrupt hemodynamic changes. And remember, this VV ECMO circuit is not providing hemodynamic support. And so you, as the bedside intensivist, need to be able to manage that decompensation and really even predict that it'll happen. This usually happens because there's a significant vasoplegia because of a systemic inflammatory response that happens, but also just plain old hypovolemia. So if you've seen the surgeons cannulating at the bedside, they'll often ask for like, hey, get a liter of LR, get another one going, because that's what they're trying to prevent. And this can be mitigated a little bit by a gradual increase in ECMO flow. Of course, we have to think about what else is happening with the patient for how gradual that can be. And usually, actually, once patients have stabilized, the vasoactive support comes off pretty quickly. Because as the patient's pH, PCO2, PO2 recovers, their hemodynamics recover. And then remember, once we have them on ECMO support, we can also turn down those really high PEEP settings that we have the patient on, which is probably impairing your cardiac filling and cardiac output in most cases. And so that by itself also leads to improvement in hemodynamics. We are constantly checking ABGs, the circuit, if you've noticed, there's always a perfusionist or a RT at the bedside, especially for the first 12 hours. For someone on ECMO, we're looking at their anticoagulation, making sure the circuit is intact and everything. And like I mentioned, anticoagulation is usually standard in patients on VV ECMO, but it is not as required as VA. And so if there is significant bleeding, we do pause it, but we try to start it as soon as possible, because while we have made improvements, these artificial surfaces are still fairly thrombogenic. So what are some of the complications in ECMO? This is a nice graph which sort of illustrates that complications related to ECMO are not just the ECMO circuit, but really from all the way from where the decision was made. And so this is where we come in. Was the decision to cannulate maybe too early, too late? Once we have accepted the patient for cannulation, did we choose the right cannula size for the patient, the right configuration? Did we cause any issues with cannulation? Remember, the 1 out of 2 patients who passed away in Caesar was due to a cannulation complication. ECMO-related complications itself that we'll go over in a minute, but also long-term complications that we can expect from any critical illness, which would be weakening, deconditioning, just reduced quality of life. And then eventually have we maybe not recognized that they are ready to be liberated or should be liberated from ECMO. So once a patient is on ECMO, though, there is a whole list of complications, which is why we are always a little bit thoughtful about whether to put someone on ECMO. The important ones being CNS. This would be CNS hemorrhage, seizures, infarcts. We can also see a lot of AKI is associated with ECMO. infections, a lot of hematologic complications. Hemolysis is very common, so you'll typically start seeing their platelet count going down, but it's most likely due to hemolysis and not really HIT. It's something that the CTICU is constantly checking for. There may be cannulation-related complications, which may be the cannula itself may fracture or circuit may malfunction, but also it can cause limb ischemia, compartment syndrome. So really a number of complications. One of the more common ones, of course, is infection, just like anyone in the ICU. So this would be just standard bloodstream infections, ventilator-associated infections. And the risk is pretty high, up to even 30 to 50% of cases. And so it's something that we are constantly thinking about whether the patient can come off ECMO or not. Of course, if there is a problem with ECMO, that can really lead to devastating hypoxemia. And so when that happens, we are not just looking for recirculation, but making sure that the circuit itself is intact, especially in some of these long-run ECMO patients. We've encountered issues with the circuit and membrane oxygenator where we have to swap them out. So now the patient's doing okay. When is it time for us to get them off ECMO? So like we saw, ECMO carries real risk. And really the question we should be asking ourselves every day, just like our intubated patient, is does this patient need ECMO support? How do we get them off safely? And in general, the rule of thumb is that intubated patients are ready for weaning once the native lung can support more than 50% of the gas exchange and the respiratory mechanics have improved. So what also suggests is if the FiO2 is consistently less than 60% with a PEEP less than 10, and the patient remains hemodynamically stable, with that, you can think about weaning the ventilator, or weaning ECMO rather. And really, while we are weaning ECMO, what we are doing is maybe pushing the ventilator a little bit. So as we are coming down on ECMO support, we are liberalizing their tidal volume slowly by increments of 1 ml per kilo on volume AC, but keeping in mind that the plateau pressure remains below 28 to 30. Or on pressure-regulated modes, we can increase the pressure again, not to a more than total of about 28. The real rule of thumb is that you want to land them on settings that you can support. And sometimes we even extubate patients before we decannulate them, depending on what is the risk-benefit of the patient remaining on ECMO. It'll determine how much we'll push the ventilator. So once we are kind of up titrating our vent support again, because we think the patient is ready for weaning, we will also, in a stepwise fashion, reduce the ECMO support. And so this is the suggested strategy by also, again, they say reduce the membrane FiO2. What you would have seen in CTICU here is they'll start reducing the flow on ECMO. Every center does it a little bit differently, but that is kind of the first step. So remember, flow equals oxygenation. So they are scaling back on the oxygenation support that the ECMO is providing. The second would be to reduce the sweep gas. So sweep gas controls the CO2 level. Again, reducing the sweep gas stepwise by 0.5 to 1 liter per minute, and then checking gases to see is the patient on the ventilator or by themselves able to sustain ventilation. And then once they're totally off sweep gas, you can actually clamp the ECMO circuit. It's called the off sweep gas challenge, and you check blood gases in that period. The clamping trial is dependent on what's happening with the patient, but you don't want to have a very long clamping trial because you don't want to thrombose the entire circuit off without any flow. And so typically anywhere from like 4 to 8 hours, up to 12 hours maybe. And then the surgeon will typically decannulate the patient. It can usually easily be done at the bedside. They leave a suture in. And you can typically take off anticoagulation once they are decannulated, unless they have other reasons to be on anticoagulation. The last thing to mention is just sort of ethical challenges on ECMO. So ultimately, we know VV ECMO is a very powerful supportive therapy. It is not just resource intensive, but it also comes with multiple complications. And really, without a clear exit strategy, it can quickly become a bridge to nowhere. And while that's not really different from maybe things that we see in the medical ICU, it's just the intensity and the resource intensity of ECMO and its complication that sort of magnifies, I think, the clinical situation a little bit. And so goal setting is maybe just as important as decannulation. So we do have a multidisciplinary approach where we involve palliative care and ethics fairly quickly in these patients if they're long run and we are not seeing sort of improvements in pulmonary function. And like I mentioned, when you're trying to do this as a bridge to we don't know what, recovery or transplant, then it's very important that you actually set the goals very upfront with the patient's family and say, we may be doing a time-limited trial or we are looking for X, Y, and Z by this amount of time. So to wrap up, I just want to go back to our cases. So the first case, which was the young man with the COVID ARDS, who we were called for ECMO for barotrauma and refractory hypoxemic respiratory failure. We did put him on ECMO for, like I said, barotrauma, and he slowly improved with ECMO, but not well enough for us to get him off ECMO. So we actually transitioned him to a bicaval IJ cannula called a transplant center in New York, gave him aggressive PT and rehab. And then eventually, after about 6 months of support, we were able to decannulate him from ECMO. This was the last CT before discharge. Just one shot of his lung base here. So really, the lungs were pretty severely damaged. The patient ended up going to a rehab facility, got acute rehab, and then did get lung and liver transplant, had some COVID-related liver injury as well, at about 5 months after discharge, and has been doing pretty well, as far as I know. And the second case, which was our status asthmaticus, so severe acute asthma, she was cannulated very quickly on day 2 with that pH of 707. And by day 7 on ECMO, her gas exchange really improved remarkably. She was extubated, actually, and then decannulated, because we can do that when the patient is, we know, is primed to do well. She is now being seen at our Yale Asthma Center and is on biologics. Just a reminder for the consult process. So we are a multidisciplinary team here, which includes us as a PCCM, cardiac surgery, cardiac anesthesia, and critical care. And the way the calls would go is that if you're from an outside center, they would call Y-axis and patch you to actually the MICU attending for respiratory failure, who would decide, or you would call one of us. You get my weekly emails, like Mark mentioned. So just to summarize, ECMO is a supportive therapy, but not a definitive therapy. It is important who we are selecting and putting on ECMO. And maybe it is most effective when we use it early and selectively, but maybe with a clear exit strategy in mind. And the benefit is mostly in providing ultra-protective lung ventilation, we think, as it does come with multiple complications. So it's important to have multidisciplinary discussions and clear goals of care setting with the family. Okay, with that, I'll take any questions.
Thank you, Astha, for a magnificent talk. So the floor is open to questions. Just a reminder, if you have questions, please wait till I can give you the mic so our Zoom audience can hear. Dr. Bazan.
Hi, thank you so much. This is awesome review and lots of new knowledge too. What does it mean to be early for ECMO? And if someone is doing well and doesn't have, for ARDS, let's say refractory hypoxemia, then they might just be fine on mechanical ventilation. How long are we watching refractory hypoxemia before we consider ECMO and not waiting until it's too late, right? Where was there a definition from a trial perspective of what that was considered?
Yeah, there's no clear definition, but if you look at the RESP score, the score starts getting worse when you're been intubated longer. So typically we would say that if you're nearing about 7 days of intubation, that's a little bit maybe long for us. And maybe, just like we talked about with that one COVID study, that maybe even the total duration of ARDS matters. We don't have this is it, day 5 of ARDS or day 10 of ARDS, and that's it. I mean, we've certainly even recently cannulated someone day 14 of ARDS. But we know that outcomes or us being able to just recover them is probably our best chances early on. And I think that just speaks to the fact that as medical intensivists, we need to do everything for ARDS early on. So we prone them, we use lung protective ventilation, we use INO, everything within the first few days. And I would say that if the P2F remains less than 100, despite what you're doing, it's time to call an ECMO center or maybe refer to an ECMO center if you're not in one.
So, Astha, as you mentioned, some of the older ECMO studies may have failed in the sense that the control arms were not necessarily getting optimal care. And one memory I have of COVID was that there were a lot of patients who were failing standard therapy with mechanical ventilation, but required some out-of-the-box thinking. Like, so for example, if you simply were to follow the ARDS network algorithm where you're just dialing up the PEEP, you might take a patient who had non-recruitable lung and essentially exacerbate shunts and see horrendous airway pressures because the patients were essentially beyond their total lung capacity. And so what ended up happening is you could sometimes improve their oxygenation by doing the opposite.
Yeah.
And so when you're assessing a patient for ECMO, how do you distinguish between patients who truly are at the end of the line in terms of what you can do with standard mechanical ventilation versus the ones who you say, let's try this or that before we move over to ECMO?
I mean, I think it's it's individualized. So this is maybe where individualized or precision medicine comes in. But we are not just looking at the ventilator settings. So we may see things like, what is the volume status of the patient? Has the patient received a trial of heavy diuretics? I think specifically to answer the question of PEEP, I mean, we do know that there is an optimal PEEP for everyone. And with the vent course with Brian and Sandy, hopefully more of us will look at the pressure volume loops and try to determine the optimal PEEP for the patients. We are also very excited that we may have the esophageal probe available to determine optimal PEEP. And that's something that we are considering using in patients who we are evaluating for ECMO, especially in those with high BMIs, because that's maybe where it's hardest for us to determine whether PEEP has been optimized.
Oh. Dr. Zay.
Two quick questions, Astha. So I didn't see malignancy or like metastatic malignancy on the contraindication list. I'm assuming it is, but that's question one. Question two is transporting on ECMO. So like we're not a transplant center, right? So if we were going to put someone on ECMO pre-transplant, do they have to be on a list somewhere else? Can we move them once they're on ECMO? It sounds like the first patient did got transplanted eventually. So I presume you can, but.
Yeah, I mean, so the first part of the question was was the metastatic malignancy. Yes, it is a relative contraindication. I mean, we honestly would not put someone on VV ECMO with an active, uncontrolled malignancy. But if it's something in the past or it's in remission, we would consider it. We would even consider it, honestly, if it's something which is very treatable. So it would be a discussion with the hem-onc team about what is the prognosis and what's the underlying disease process. We have done a few patients with some sort of hematologic malignancies, not so much solid tumors. The second part of the question, which related to transport on ECMO. So yes, it is possible to transport on ECMO. Typically, transplant centers will not take patients with acute lung failure unless we've demonstrated that they can, they can mobilize and they have a good neurological status. A lot of the things that they wanted for that first case with COVID ARDS. But yes, if they are listed for transplant somewhere, and we've had a couple of these cases, say one of our ILD CF patients comes in who was already kind of set up and being looked at by a transplant center, even if they're not actively listed, if you put them on ECMO and call the center fast enough, they will come and take them. Similarly, we can mobilize patients we have a mobile ECMO team, and so they will go to hospitals really all around the state and the region. They've gone out of state too, to put patients on ECMO and get them back to us. So both ways are possible. I think it's harder with just an acute kind of pulmonary respiratory failure without a patient being worked up to be accepted to a transplant center. But I don't think it's unheard of. So we did have a case of someone with what we felt was like a AIP sort of a picture with a very positive autoimmune workup that was just starting when she decompensated. And the patient, we cannulated her and quickly moved her to a transplant center for the rest of her care. So
maybe one more question. So I'm curious about the asthma story. And if you read the classic asthma respiratory failure literature, particularly surrounding permissive hypercapnia, there's this lesson that has often been stated that patients otherwise healthy can tolerate just about any CO2 as long as you oxygenate them. So I'm curious about how you think about that in the context of putting somebody on ECMO for hypercapnia. Like I know it's scary, but patients, I think many of us have seen patients like that survive if you
I mean, I think asthma is one of those odd challenging scenarios where sometimes we've just waited long enough and their bronchospasm improves and their airway mechanics improve and we can let them break through. I think it is, we really, so that pH cutoffs of 7.25 is not what we are thinking about for asthma. We are really thinking maybe for a pH less than 7.15, 7.1 even. But if we start seeing really significant, ROP with dynamic hyperinflation, hemodynamic effects, I think most of us do jump on ECMO. I will say that, as someone maybe who's used to ECMO, I would maybe pull the trigger a little bit faster in calling versus maybe say someone who's had a more experience with just tolerating patients with a pH of 7.05 and letting them ride. I think it all depends on what's happening hemodynamically with the patient. What we don't want happening and why we are looking at the pressures constantly in these patients is we don't want them to get barotrauma, because that's when they really have long runs. Otherwise, asthmatics do really fantastic on ECMO. It's a short ECMO run, and they get better really quickly. So if we land into trouble with like a pneumomediastinum or a pneumothorax, then that really complicates outcomes for them.
Well, Astha, thank you for an absolutely superb lecture. I can't believe we got it for free, because I think you should charge tickets for your ECMO lectures. So thank you so much for today.
Thanks.